So I welcome Professor Dr. Leo Hank to this sessions of 46th episodes of Apollo Mumbai Critical Care Learning Network. Just a brief introduction about him. So Leo Hank is the Professor of Intensive Care Medicine and Clinical Scientist at the Erasmus University Medical Center in Rotterdam, the Netherlands. His clinical interest and research focus on mechanical ventilation, weaning, and respiratory physiology. He is invited speaker at many international conferences, former chair of the Acute Respiratory Failure Assembly of the ERS, and current research committee member of the ESICM, European Society of Intensive Care Medicine. He is also associate editor for the American Journal of Respiratory and Critical Care Medicine. So with a vast experience, knowledge, and his teaching base, he is going to speak today on our platform regarding the weaning and its challenges, weaning failure and its challenges. So, and with us, our all moderators. So I request all of you to put your questions in the chat box so that at the end of the discussion, we'll take the questions one by one with him. So with this, I welcome Dr. Leo. So please, sir, start the sessions and then we'll have the interaction session. Thank you, sir.
Thank you very much, Dr. Paddy, for this very nice and kind introduction. It's really a pleasure and honor to present here today for my fantastic colleagues from India. It's really a pleasure and honor. Thank you so much for the invitation. So today we're going to discuss weaning from mechanical ventilation. And I think that is a very important topic from patient perspective, from perspective of doctors and nurses. And the underlying pathophysiology, as you already mentioned, is very interesting. So these are my disclosures. I don't think there's anything really related to the current presentation. And what I would like to do in the next 45 minutes or so, discuss first a little bit about what is actually weaning. How do we define the weaning process? What is the role of weaning trials, spontaneous breathing trials? And very important, if a patient cannot be weaned from the ventilator, what is the underlying reason? What is the differential diagnosis for difficult weaning from mechanical ventilation? So I think if you would ask clinicians, when does the weaning process start? Some would say at the moment of endotracheal intubation, or others would say when we switch from controlled ventilation to assisted mechanical ventilation. And I think this is true from a clinical perspective, but from a more scientific perspective, we have defined the start of weaning at the moment of the first separation attempt. So the first time the patient performs a spontaneous breathing trial, or the first extubation, marks the start of the weaning. So why is that important? Because now we can define three different groups. So group one are the patients that are successfully weaned within 24 hours after the first SBT. And this group has a mortality of around 6%, pretty low. The intermediate wean group, which means between day 1 but successfully weaned before day 7 after the first SBT, has a mortality of around 17%, while patients with prolonged weaning, so taking more time to be liberated from the ventilator than 7 days after the first spontaneous breathing trial, have much higher mortality, almost 30%. So I think this is important information. The more time it takes to wean a patient after the first spontaneous breathing trial, higher the mortality. So it is important, as we will see later on, that a patient is weaned from the ventilator as soon as possible. So right here, you'll see a quite typical trajectory of a patient in the ICU. So after endotracheal intubation, there is a moment of a certain time period of controlled mechanical ventilation. There is a respiratory improvement. So at some point, we are considering the first spontaneous breathing trial, and there's quite some discussion. What would be the right time to perform the first spontaneous breathing trial? And now, in WeanSafe, we have defined the so-called weaning eligibility criteria. In a kind of consensus, we agreed that the first weaning trial should be performed early. So when PEEP is at or below 10 centimeters of water, FiO2 is at or below 0.5, and vasopressors are tapered to a low dose. This is the moment that the first spontaneous breathing trial should be performed. And if the patient fails, succeeds in spontaneous breathing trial, he should be ready for extubation, or when the patient fails the spontaneous breathing trial, is reconnected to the ventilator. So then there's quite some discussion, I think, among clinicians. If I'm going to ask to raise your hand right now, what would be the best way to perform a spontaneous breathing trial? I think some of you would say, well, disconnect the patients from the ventilator and perform a T-tube trial. Others would say, no, we need a little bit of CPAP during the SBT. While others would say, no, because of the resistance of the endotracheal tube, a little bit of inspiratory support should be provided during a spontaneous breathing trial, while others say, no, it should be a little bit of pressure support and a little bit of PEEP. And I think, and that's what we have learned from WeanSafe, and I come back to that later, but WeanSafe is a very large observational study we have just published in Lancet Respiratory Medicine that includes an observational study from 500 ICUs around the globe, including centers from Asia, from India, everywhere around the globe. And it was nice to see that the way spontaneous breathing trials were performed was very different from country to country and even from hospital to hospital. But what is the best spontaneous breathing trial? And I think this is a very interesting physiological meta-analysis. And the aim of this meta-analysis was to determine what is the impact of the type of spontaneous breathing trial on inspiratory effort. So this is a quite complicated picture, but I think it provides important information. If we compare pressure support versus extubation, so the work of breathing during low pressure support, 5 or 7, versus the work of breathing during extubation, you will see that with pressure support, the effort is significantly lower as compared to extubation. Moreover, if you compare all different types of SBTs to DPs, pressure support without CPAP, you will see that right here, the work of breathing after extubation is best reflected by a T-tube trial or low CPAP. So if we want to simulate the work of breathing after extubation, the best way to go forward is to perform a T-tube trial or perhaps a low CPAP trial. And interestingly, 2 large studies on this topic have recently been published. So this is the one in JAMA 2019, including patients ventilated for more than 24 hours. And they compared a 30-minute spontaneous breathing trial with low pressure support, 8 of pressure support, versus a 2-hour T-piece trial. And their primary outcome was successful extubation. And as you can see right here, successful extubation was 82% in patients with pressure support versus 74% in the patients with the T-piece trial. So this study suggests that the best way to perform a spontaneous breathing trial would be low pressure support. But I think there's an important limitation to this study. And the most important one, look right here, the percentage of patients that were extubated after the very first spontaneous breathing trial. So this was like 93% in the patients that performed this low pressure support trial. So think about it. You are doing a screening test to predict if a patient can be weaned from the ventilator. And the screening test is positive in 93% of the patients. What this tells me is that in this study, the SBTs were performed rather late. Because if you are doing a screening test, you want a lot of patients to fail, right? If 93% of the patients pass the spontaneous breathing trial, performing a spontaneous breathing trial does not make much sense. It only makes sense to do a screening test when a considerable number of patients fail. So I think that is an important limitation of this trial that you have to keep in mind. So therefore, this study is interesting, I think, published earlier this year in the New England Journal of Medicine, also including patients that has been invasively ventilated for more than 24 hours. And they recruited patients at high risk of extubation failure. And that means patients older than 65 years of age and patients with cardiopulmonary past medical history. Nice, the weaning eligibility criteria, PEEP 8 or lower, FiO2 0.4 or lower. So at that time, they performed the first spontaneous breathing trial, and they compared 8 of pressure support versus TPs. The primary outcome was a composite endpoint as days alive without invasive mechanical ventilation from the first spontaneous breathing trial. And as you can see right here, no significant difference. So there's no significant difference in the duration of invasive mechanical ventilation from the first spontaneous breathing trial, whether this trial was done with low pressure support or with TPs. Also, I think this is more important, the number of patients that required reintubation within the first 7 days was not significantly different between these two groups. Okay, as you can see right here, for both groups, it's around 12–13%. So I think, looking back at the physiological studies and this trial we just discussed in the New England Journal of Medicine, I would prefer to conduct a spontaneous breathing trial with zero assist, either a T-tube trial or you just reduced PEEP and inspiratory support on the ventilator, both to zero, because this best reflects the work of breathing after extubation, and it's really supported by this New England Journal of Medicine trial. And I'm sure there's going to be a lot of questions about this, and I'm happy to hear your ideas, but I think based on the literature, it's reasonable to go forward with this. Also, I already mentioned this briefly. This is the wean-safe study that we just published in the Lancet Respiratory Medicine a couple of weeks ago. And the paper is full of data, and there's a lot more data to come. I want to draw your attention to this very important conclusion, that a delayed initiation of weaning or a delayed initiation of the first spontaneous breathing trial is independently associated with weaning failure. It's independently associated with longer duration of mechanical ventilation. So for your center, I think it is very important to define your weaning eligibility criteria. When are you going to do the first spontaneous breathing trial? And again, in wean-safe, we defined PEEP below 10, FiO2 below 0.5. In the TEAL study, they had little bit lower criteria, P below 8 and FeO2 below 0.4. I don't think that matters too much, but it is important to have strict weaning eligibility criteria and perform the SBT. And again, if 93% of your SBTs is successful, you're probably too late with the first SBT. So I think this is a very important learning point. Second, so you have performed your spontaneous breathing trial. Patient is successful, and there are other criteria, sufficient cough, neurology is okay, patient is extubated. But if the patient fails and is reconnected to the ventilator, I think it is really, really important that you think about the underlying reason. Why is this patient actually failing the spontaneous breathing trial? And looking at it from a physiological perspective, you have to realize that a spontaneous breathing trial, whether it's successful or not, depends on the balance between the capacity and the load put on the cardiopulmonary respiratory muscle system. And the capacity is determined by the respiratory drive of the patient, respiratory muscle function, oxygen transport, systolic function, diastolic function, cognitive function, and so on. The load imposed on the system during the spontaneous breathing trial depends on the respiratory resistance, respiratory compliance, intrinsic PEEP, gas exchange, oxygen consumption. So if there is a disbalance between the capacity and the load imposed on the system, the patient will fail a spontaneous breathing trial. And I know it will be difficult at the bedside to actually go through all these different items. And that is why a couple of years ago, we wrote this quite simple ABC of weaning failure. So if your patient fails a spontaneous breathing trial, look at the patient and think, is this a problem with the airway or the lung? Is it a problem with the brain, cognitive function? Is this cardiac dysfunction? Is it diaphragm, respiratory muscle dysfunction, or endocrine metabolic dysfunction? So let us go through this in some more detail. Airway dysfunction. In particular, in patients with a tracheostomy tube, a malposition of the tracheostomy tube could contribute to difficult weaning from mechanical ventilation. This is a very nice study, quite old, but I think it's still important. Analyzing patients admitted to a long-term weaning facility in the US. And actually 1 in 3 of the patients admitted to this long-term weaning facility failed because of a problem with malposition of the tracheostomy tube. And most frequently, it was the posterior tracheal wall occluding the distal tip of the tube. As you can imagine, if this is your tracheostomy tube and it bulges into the smooth wall of the trachea, it partly occludes the tracheostomy lumen. And you don't have these problems with positive pressure ventilation. But when the positive pressure during an SBT is removed, occlusion or partly occlusion of the tracheostomy tube may occur because of this smooth wall of the trachea. So quite simple, if a patient is failing a spontaneous breathing trial, take your bronchoscope when the patient is disconnected from the ventilator and look if there is a malposition of your tracheostomy tube. Other issues could play a role as well, development of granulation tissue, the cough into the stoma, but that's less likely. So as an example right here, I mean, this takes you like 1 minute. You take the bronchoscope, look at the tracheostomy tube, at the tracheal wall, like here, there's no occlusion, so you know this is not at play. Of course, it is important to disconnect the patient from the ventilator such that the posterior wall of the trachea is not stented by the positive pressure. The other thing, so main airway plays a role, but also the lung in itself. So check if the patient has residual obstructive airway disease. Is there still high airway resistance? In this case, consider bronchodilation, steroids. Low compliance of the chest wall, for instance, because of ascites, because of pleural fluid, edema. I think that's something that you should consider. Quite easy. I think a lot of ICUs worldwide do have ultrasound available. I think you had a lecture on ultrasound in this series a couple of weeks ago, and I'm sure they've demonstrated you how easy it is to recognize pleural fluid, but also to recognize these B lines consistent with pulmonary edema. If you see that a patient fails a spontaneous breathing trial and there is a lot of pleural fluid, or the patient has B lines, I think you should consider diuretics to make the chances of successful extubation with the next attempt more likely. So in this paper, and I'm not going to discuss it into too much detail, but in this paper, we discussed the role of lung and pleural ultrasound in patients weaning from mechanical ventilation. So that was in a nutshell, the role of the A. B, I think all clinicians will recognize that patients that are agitated, patients that are delirious, confused, are much more likely to fail a spontaneous breathing trial or fail an extubation. And it's not easy to treat delirium agitation, but I think this is an interesting trial. This is a trial, the so-called DALIA trial, that studied the effect of dexmedetomidine added to the standard of care on ventilator-free days in patients with agitated delirium. And they found that adding a low dose of dexmedetomidine in selected patients, so in agitated patients, indeed resulted in more ventilator-free days. I'm not saying that this is like the best way to treat the patients, but at least there is some evidence to show that dexmedetomidine may be a good choice and that treatment of agitation anxiety in patients that are difficult to wean is important. Okay, next. I think cardiac dysfunction plays a very important role in difficult weaning from mechanical ventilation, even in patients that do not have a past medical history of cardiac disease. As you will know, the transition from positive pressure to negative pressure in the thorax with the spontaneous breathing trial has a large impact on the cardiovascular system. And I'm not going to discuss this in detail, but just some highlights. The reduction in intrathoracic pressure increases left ventricular afterload, may increase left ventricular diastolic pressure, and in selected patients result in pulmonary edema. The high adrenergic tone, increase in CO2, may increase venous return, increase left ventricular afterload, increase in diastolic pressure, pulmonary edema. In some patients, the increased work of breathing with the loss of positive pressure due to mechanical ventilation may provoke myocardial ischemia. This reduces the left ventricular compliance, increases left ventricular and diastolic pressure, pulmonary edema. So just keep in mind that the transition from positive pressure in the thorax to negative pressure during a spontaneous breathing trial may result in cardiac dysfunction. So I still think that the Swan-Ganz catheter is like the state-of-the-art diagnostic technique to diagnose diastolic or systolic dysfunction. But honestly speaking, I think very few ICUs will actually use the Swan-Ganz for the differential diagnosis in difficult weaning. But I think it's still an option for complicated patients. But there is some good news because the changes in BNP or pro-BNP have a pretty good sensitivity and specificity to diagnose cardiac failure during a spontaneous breathing trial. So it's not just a single value, but if you take BNP sample or pre-BNP, pro-BNP sample before and at the end of a failed spontaneous breathing trial, and there's an increase by more than 12%, there is a high likelihood that cardiac dysfunction plays a role. And if you do not have BNP or pro-BNP in your ICU, even an increase in plasma hemoglobin has a pretty good sensitivity and very good specificity to diagnose the so-called weaning-induced pulmonary edema. Because if during a spontaneous breathing trial, the patient develops pulmonary edema, it means fluid transitions from the circulation into the lung, pulmonary edema, and hemoconcentration will develop. So an increase in hemoglobin or increase in albumin during the spontaneous breathing trial has a very good sensitivity and specificity for development of pulmonary edema. And I think you can do that in every ICU. Also, don't forget, in patients failing a spontaneous breathing trial, just perform EKG at the end of a spontaneous breathing trial to see if there is signs of cardiac ischemia. Of course, I think you're very well aware, if this plays a role, systolic dysfunction, diastolic dysfunction, coronary artery disease, take the appropriate measures. Fluid removal in diastolic dysfunction, very important. Treat hypertension, underlying myocardial ischemia. And I think it's a pretty old study, but I think it's a fantastic study. So these were patients with COPD, but no past medical history of cardiac failure. They did have hypertension, but not any cardiac operation or left ventricular failure or whatsoever. These patients were invasively ventilated, but failed 3 spontaneous breathing trials. And now the authors performed extensive physiological measurements before, in a spontaneous breathing trial, before treatment with nitroglycerin and during treatment with nitroglycerin. Look what is happening. During the first spontaneous breathing trial, you'll see here systolic blood pressure. At the time, they were still on the ventilator. At the start of the spontaneous breathing trial, at the end of the spontaneous breathing trial. And you'll see the mean systolic blood pressure increases from 149 to almost 180. So patients became hypertensive during the spontaneous breathing trial, and also wedge pressure increased from 15 to 23. And I think this is consistent with diastolic heart failure. Now, in the second spontaneous breathing trial, nitroglycerin was administered with the goal to keep the systolic blood pressure below 140. So again, at the start of the spontaneous breathing trial, systolic blood pressure 144. And now with nitroglycerin, development of hypertension was actually prevented. And also, there was no increase in pulmonary capillary wedge pressure. And even more interesting, during the first spontaneous breathing trial, all patients failed after a mean of 49 minutes. But the day after, with nitroglycerin, 92% of the patients had a successful SBT and 88% successful extubation. So I think what I have learned from this paper, and I'm using it quite a lot in our ICU, if a patient fails spontaneous breathing trial and becomes hypertensive, we just perform a second spontaneous breathing trial with continuous nitroglycerin to keep systolic blood pressure below 140. And quite often, we are successful in the next SBT. So I think this is very important. Cardiac failure is a frequent cause for difficult weaning from mechanical ventilation, also in patients without a past medical history. And it does have an impact on your treatment strategy. And well, you were thinking, why is this Christmas tree here? Well, remember, in this study, we only had patients with COPD. And if you think that COPD was the reason for failing the spontaneous breathing trial, you can treat these patients with bronchodilators until Christmas, but you're not going to extubate them. You're not going to successfully wean them. You have to treat the underlying diastolic dysfunction. Okay, let's go forward. Very important, diaphragm dysfunction. I think in addition to cardiac dysfunction, this plays a very important role in difficult weaning from mechanical ventilation. So why do patients develop diaphragm dysfunction while being on the ventilator? Well, there's an important role for sepsis, important role for inadequate nutrition while patients are on the ventilator. They develop oxidative stress. This has an impact on protein synthesis, on protein degradation in the diaphragm. Patients will develop atrophy and diaphragm weakness. But there's also a very important role for mechanical ventilation in itself. Because during controlled ventilation, the diaphragm is inactive. Inactivity results in disuse atrophy and weakness. But what we are recognizing right now as well is that insufficient unloading. So a patient on pressure support with low pressure support and therefore high effort by the patient may result in load-induced injury of the diaphragm. And this also results in weakness. As you probably know, diaphragm weakness develops frequently in our ICU patients. And this paper by Samir Jaber, published a couple of years ago in the Blue Journal, after only 3 or 4 days of controlled mechanical ventilation, pressure generating capacity of the diaphragm was decreased by 25%. So dysfunction of the diaphragm develops rapidly. And it also has been demonstrated that diaphragm weakness is associated with difficult weaning. Patients that develop diaphragm weakness are more likely to be readmitted to the ICU and have higher mortality. I'm not going to discuss this paper in detail, but what they actually have shown that at the time of the first spontaneous breathing trial, 63% of the patients had developed diaphragm weakness. And the interesting thing, that 1 in every 3 of these patients did also have ICU peripheral muscle weakness, but a lot of the patients with diaphragm weakness did not have peripheral weakness. So if your patient has strong function of the arms or legs, this does not exclude clinically important diaphragm weakness. It's important to remember. So these are some data from our own lab where we have taken biopsies of the diaphragm of ICU patients. So patients that went on for laparotomy, thoracotomy, the surgeon took a biopsy, and we indeed found atrophy, disuse atrophy of diaphragm fibers. And we also found infiltration of inflammatory cells, neutrophils, macrophages. Moreover, if you look carefully at the diaphragm, and this is a control patient, you'll see the very nice striation of the diaphragm muscle. But in ICU patients, there are areas where this normal striation is completely lost. And this is what we call sarcomeric disruption and may be consistent with load-induced injury. So remember, diaphragm weakness in ICU patients is not just inactivity. There is an important role for probably inflammation and load-induced injury. I'm going to skip this. So this is important, I think. If a patient is on assisted ventilation, we do know that if patients do not have any breathing effort at all, this patient is at risk for disuse atrophy. But if a patient has a high breathing effort, this is damaging to the respiratory muscles as well. Or at least it is very likely that it's damaging to the muscles because it may result in load-induced injury. As you can imagine, if you're using your biceps in a high load 24 hours a day, injury is going to develop. And it is possible that this happens in the diaphragm as well. So what is this so-called diaphragm protective mechanical ventilation? It means that we keep the effort of the diaphragm within physiological limits, a normal breathing effort. And that's actually what we have tried in this paper published about a year ago. I think this is the first study on lung and diaphragm protective ventilation. It's a feasibility study in patients that were in our ICU on pressure support ventilation. They were all equipped with a double balloon catheter, so we could measure transdiaphragmatic pressure, and they were randomized between the so-called standard of care or diaphragm protective ventilation. And diaphragm protective ventilation means the diaphragm is every breath generating a pressure between 3 and 12 centimeters of water, more or less the same as you have as you're sitting here behind your computer. So what we have found that in patients in the control group, only 35% of the breaths were within the so-called diaphragm protective range. So these patients had too high or too low effort of the diaphragm. While if we titrated effort into the diaphragm protective range, more than 80% of breaths were within the so-called limits of diaphragm protective ventilation. So diaphragm protective ventilation is feasible in ICU patients. And the nice thing is, it does not challenge lung protective ventilation because tidal volume and transpulmonary driving pressure were exactly the same. So the study shows that it is possible to deliver diaphragm protective ventilation, but it requires additional monitoring. And it's not the topic of this talk. Perhaps we can discuss it in the future. But how do we monitor respiratory effort? I think the state of the art, as we did in our trial, is esophageal or transdiaphragmatic pressure. But I really think that very few people in India, but also in Europe, in the US, very few centers actually use esophageal pressure. But now, and I think we have recently validated airway occlusion pressures to assess diaphragm effort. The P.1 or P-OC are, especially the P-OC, is a very nice way of assessing diaphragm effort. Okay, so your patients fail weaning from mechanical ventilation, and you are interested to know if the respiratory muscles are indeed weak. How do we diagnose it? Well, the state of the art would be magnetic stimulation, but I don't think that anyone in the world is actually using this for clinical care. But what you could use is this rather simple and rather cheap handheld devices that you can connect to the endotracheal tube or the tracheostomy tube, and you just ask your patients to take a maximum inspiratory breath, and you can measure maximum inspiratory pressure and maximum expiratory pressure. And if your maximum inspiratory pressure is more than 40 centimeters of water, it excludes diaphragm weakness. Remember, most of you, as you're sitting here, the maximum inspiratory pressure would be around 100. So if your patient can generate a pressure of 40 or 50 centimeters of water, it is unlikely that diaphragm weakness explains difficult weaning. A lot of people are asking, can we use ultrasound? Because a lot of ICUs now do have ultrasound available. So can we use ultrasound to assess respiratory muscle strength and function? Well, that's what we have discussed in this paper, published like 2 years ago in Intensive Care Medicine. And I really think that ultrasound can be helpful. And this is your ultrasound probe. And you just put it at the subcostal position, using the liver as a window, you will get this view. So right here, the probe, the liver, and on top of the liver, you will see this line, and that's the diaphragm. And if I start this video, you will see that during inspiration, the diaphragm moves towards the probe. And now a deep inspiration, diaphragm moves towards the probe. If this happens, then you can exclude severe diaphragm weakness, because if the diaphragm is really weak, it will not move towards the probe. This is really simple. It takes you like a minute to diagnose if the patient has severe diaphragm weakness. You will see the reference values right here, but if you just see that the patient takes a deep breath and the diaphragm moves towards the probe, you exclude severe diaphragm weakness. But it is important that you measure this without inspiratory support. So preferably if the patient is disconnected from the ventilator or just with CPAP, because if you can imagine that even if the patient is on controlled mechanical ventilation, the diaphragm will move downward, even without any effort. So measuring this, measuring excursion of the diaphragm can only be done without, should only be done without inspiratory support. So that's one, just looking at movement of the diaphragm. A little bit more sophisticated is looking at thickening fraction. You take the linear probe, put it in the mid-axillary line, and you will be able to identify the diaphragm. So right here, this is the pleural line, peritoneal line, and in between is the diaphragm. And if I start the video, you'll see, well, first let's see. As you know, any muscle that contracts thickens, right? Same thing for the diaphragm. So now in this patient, during inspiration, you'll see that the diaphragm thickens. And you can actually calculate the so-called thickening fraction. So this is the thickness and inspiration minus thickness and expiration divided by thickness and expiration. And it will give you a thickening fraction. And it has been suggested that the thickening fraction somewhere between 15 and 30% is consistent with normal effort. I would really say be very careful with this interpretation. The way I use it for the diagnosis of severe diaphragm weakness is just looking at, is there any thickening fraction at all? And it's really hard to say, and I can show you some papers here. This is a very nice paper by Martin Dress, published in Anesthesiology last year, that the correlation between thickening fraction and the pressure developed by the diaphragm is really poor in ICU patients. So you cannot say if the thickening fraction is 50%, the diaphragm develops a pressure of 10 centimeters of water. That's very imprecise. But if you do have a patient on the ventilator, there is a reasonable thickening fraction, you know that it excludes severe weakness. Okay, so if a patient has developed severe weakness of the diaphragm while on the ventilator, of course, most likely it is critical illness associated diaphragm weakness, or what some people would call VIDD. But there is a differential diagnosis because, I mean, a patient admitted for pneumonia and severe respiratory muscle weakness, it could be the first presentation of a neuromuscular disorder, ALS, multiple sclerosis, phrenic nerve disease, and so on and so on. So always keep in the back of your mind the differential diagnosis of diaphragm weakness in these patients. So briefly, for the last 10 minutes or so, how can we improve respiratory muscle strength? So now we found patient fails weaning for mechanical ventilation. We found that the respiratory muscles are weak. Can we improve respiratory muscle strength? And I think it's quite disappointing that today we do not have any drug to improve respiratory muscle strength, right? We do have different drugs to improve cardiac muscle performance, for cardiac failure, but we don't have any drug available today for respiratory pump failure. We are doing some research with inotropes. We are sometimes using I'm losing the word now right now. So agents that can improve strength, so androgens, can anabolic, yes, that's what I was looking for, anabolic steroids, but there's no good trials out there. But what we could do is inspiratory muscle strength training, and there are different devices available. So this is a relatively cheap disposable device where you can set an inspiratory resistance, and that is what they have done in this study. Train patients 5 days a week for a maximum of 28 days, and either inspiratory muscle strength training or control at the start and at the end of the period. And as you can see, there's no change in inspiratory muscle function in the control group, and patients that were subjected to inspiratory muscle strength training increased inspiratory strength and were more likely to be liberated from to be weaned from the ventilator. So 71% in the group of patients with IMT versus 47% in the control group. It is a relatively small study, but I think this and other studies have demonstrated that in selected patients, inspiratory muscle strength training can improve muscle strength, not much discussion about it, and probably increase the success to be weaned from mechanical ventilation. Well, this is another trial more recently published early this year and had more or less the same outcome. A trial from Brazil where they demonstrated that it improves respiratory muscle strength and suggests that it improves weaning from mechanical ventilation. I'm not going to discuss this in detail. Given the time, I think perhaps at some other time we can discuss it. There's some interesting options on coming up to improve muscle strength. And one of these is the so-called, so this is a Chinese invention, this is an American invention, the so-called lung paces. Can you, either with surface electrodes or invasively, stimulate the diaphragm to train it in patients that cannot be subjected to inspiratory muscle strength training? I think it's a very interesting development, but there's not much data out there to show that it improves clinical outcome. Very nice study here about the lung pacer device, and they actually show that stimulation of the diaphragm using this device improves inspiratory muscle strength. Very nice, but it fails to improve the success of weaning or the duration of mechanical ventilation. Well, the study was not powered for this, but it makes you think. I mean, you can improve strength, but in this population, it did not improve clinical success. There's new trials ongoing, so I'm eager to see what is actually happening here. But I think for most of the patients, just doing a relatively simple inspiratory muscle strength training would be the best way to go forward. And most of your physiotherapists can actually do this. So we haven't discussed much the role of the expiratory muscles. As you know, expiratory muscles, the most important are your lateral abdominal wall muscles, play a very important role in coughing, limiting development of atelectasis, and to maintain patency of the central airways. I mean, patients can go through the spontaneous breathing trial, be extubated, but usually if they fail extubation, there is an important role of expiratory muscle weakness, because all clinicians will recognize it, they just don't have the strength to cough. So in this randomized controlled trial, we tested whether training activation of the expiratory muscles in synchrony with mechanical ventilation can improve expiratory muscle strength. And indeed, we measured thickness of the expiratory muscles with ultrasound and found that electrical stimulation with surface electrodes of the expiratory muscles improved thickness of the muscles, maybe hypertrophy, and also increased the chances of being successfully extubated. Well, that was not the primary outcome, so we have to be a little bit careful with the conclusion, but I think it's intriguing finding, and we're now conducting a very large study, international randomized controlled trial, to see if this electrical stimulation of the expiratory muscle indeed improves extubation success. Okay, and the last component of my ABC is endocrine metabolic dysfunction. It's a little bit harder to grab, but in a patient that is difficult to wean, always taking your differential diagnosis: adrenal dysfunction, thyroid dysfunction, and adequate nutrition. Oh, excuse me. So with that, I think we're close to the end of this presentation. This is a very nice trial, just published in Lancet Respiratory Medicine, on the role of non-invasive ventilation after extubation, but I think I'm going to skip it right now because of the time. If you want, I can share my slides. I can send it to the organization of this event, and you can look at the literature. So what I've tried to show you in this last 45, 60 minutes, how do we improve weaning from mechanical ventilation? Very important, perform an early SBT. For instance, PEEP of 10, FiO2 of 0.5, low dose of vasopressors. If the patient is successful in the SBT, and I would prefer disconnection from the ventilator or zero pressure support, zero PEEP, and the patient has adequate cough and neurology, extubate. If the patient fails an SBT, you reconnect him to the ventilator, but also, what is your differential diagnosis? Why does this patient fail, and can I fix the problem? I think that's a very important message as well. And with this, I would like to end my presentation. Thank you so much for your attention.
Thank you, Dr. Leo, Professor Leo. So I think that's a very lucid talk, and this is all the slides are based on evidence, and actually it's a really appreciable effort that you are the part of the major trials of the weaning, like you already have mentioned, like the WinSafe trial, which is a very recent trial, and the other trials like diaphragm protective ventilation. Now the concept is changing from the lung protective ventilation to the diaphragm protective ventilation. And you have already mentioned that both disuse and overuse both can cause this diaphragmatic problem during the weaning. So that one has to take care of. Also, your trial like ABC of weaning failure, that trial also, I think it is most of the intensivists, they follow the same protocol, the ABC of the weaning. Second thing is also you have highlighted the role of the NTG during the weaning process, like particularly if the patient has high blood pressure and is going into diastolic dysfunction, so probably low dose of NTG can sometimes helps. And also you have pointed out rightly the role of dexmedetomidine in the very low dose sometimes helps to facilitate the weaning. So most of our colleagues actually nowadays the concept is changing, like this kind of sedation with analgesia. So it sometimes can help the patient to relieve their anxiety. Second thing also, what you have highlighted, I just want to highlight, I just want to point out in this session that role of ultrasound is very important, like the end occlusion pressure P0.1. It is one of the important measures. Many of the newer ventilator has that setting where you can just press the button and you can fairly predict the weaning success or weaning failure, if I'm not wrong. Second thing is diaphragmatic weakness, which is a very important issue actually. This do not correlate with actually the peripheral muscle weakness. If I'm not wrong, you have pointed out. The patient has a very good peripheral muscle power, but he may have a very significant diaphragmatic weakness. That one has to keep in mind during the the weaning. And also the thickening fraction, but actually now used as a most of the centers as a screening tool during the ultrasound by most of the intensivists. And also one of the thing what I like prediction of the pulmonary edema, before weaning trial and after the weaning trial, how do you know that this patient has a very high likelihood of going into pulmonary edema, like the rise in the hemoconcentration, the hemoglobin level, or the rise in the albumin level, if I'm not wrong. So that actually one of the important questions I would like to ask to you after this session. And second thing is the future strategies. Of course, these are the future strategies, which is very important, and it is one of the newer innovations, and sometimes called the innovations in critical care medicines, like your lung pressure pacer and diaphragmatic pressure, particularly the phrenic nerve stimulation, is now gaining popularity. Though the evidence is very very poor, but it is coming up in a big way. And also the expiratory muscle strength, and one has to be very meticulous, like the expiratory muscles are more important than the inspiratory muscles. So with this, definitely appreciate and congratulate and thanks from our critical care department, and we'll be taking the questions in next 10 to 15 minutes. Though there are a lot of audiences, more than I think 200 to 50 audiences. This is streaming across the India and most of the channels. So we'll only be taking very few questions. So the first question is the role of this ventilator, like neurally assist the NAVA ventilator. Most of the centers now this newer ventilators are coming, which actually measure the diaphragmatic function. What is your experience? And NAVA versus the proportionate assist ventilation. This is one. And second is just I would like to little bit highlight regarding the WinSafe study, because this is a very recent study. How is the strength? What are the different populations you have selected? And whether it is a multicentric trial, and how did you conduct the trial? If you can just highlight, it will be beneficial to all our intensivist friend here. Thank you.
Thank you very much, Dr. Padi, for this fantastic summary of the presentation. I think you really had the highlights. Regarding your first question, I had a couple of slides on NAVA ventilation in the presentation, but because I had so much, I decided to delete, but I think it's an important point. We have published a trial. So for people who are not very familiar with NAVA, NAVA is an assisted ventilator mode that uses the electrical activity of the diaphragm to control the ventilator, right? It has a dedicated nasogastric tube. It measures the electrical activity of the diaphragm. And I think one of the benefits of NAVA is that it is very good at improving patient-ventilator interaction. And we had a recent paper published in anesthesiology from the Chinese group that nicely demonstrated that in patients that are difficult to wean from mechanical ventilation, NAVA, as compared to pressure support ventilation, improves weaning outcome. So patients on NAVA had shorter duration of weaning. So I think, yes, that in selected patients, difficult to wean from ventilation, there is a role for NAVA. And we do have a lot of experience with NAVA, and I really like it in patients that have a lot of dyssynchronies, like patients with COPD, or patients with very severe muscle weakness. I think these are great patients for this NAVA mode. The problem is that there's only one ventilator brand that sells it, right? So even as compared to PAV, I think NAVA has benefits. But the problem is it's only one ventilator mode, and it is well, I'm not sure about the price in India, but the catheters are relatively expensive. So the second question about WeanSafe. So as I mentioned, WeanSafe is a large observational study. So we have asked colleagues around the globe, in your ICU, take 4 weeks. And for every patient that is admitted, daily describe what's going on. What are the ventilator settings? What are the levels of sedation? What are the inotropes, vasopressors? What kind of modes are you using? Is the patient extubated? Is it successful? So we got, for like 6,000 patients being ventilated for at least 2 days, a very good insight what is happening in the weaning process. And the first paper has just come out. I'm sure there will be 10, 20 papers to come. And for colleagues in India that have contributed to Wean Safe, please send in proposals. You can contribute to data analysis. You can write the papers based on Wean Safe. This is open right now for everyone that has contributed to Wean Safe. And within a couple of weeks, it's actually open for everyone. So if you read the paper and you think, well, I'm very interested in tracheostomy, or I am very interested in SBT, you can send in a proposal and can analyze the data. So it's open for everyone. I think that's a very strong part of the Wean Safe.
So the centers can enroll themselves soon. You mean
definitely? Yeah. So you can enroll. You can actually send in research questions, and if approved by the executive committee, and most likely, you can do the analysis and write the paper. I mean, the data is open for everyone.
Oh, that's great. That's great.
Okay. So Professor Hank, yeah, I'm Dr. I have one question for you. So basically, we have seen that over a period of time, the weaning methods have changed. So earlier, we probably used to use TPs as a method to really see whether patient is ready for extubation. And then nowadays, we have switched over from TPs to CPAP, directly getting extubated. And then, do we have any strategy which will help us, whether we can give this trial and continue with the, illicit patient for some time, understand the mechanics, and whether PPs can also be given as a spontaneous breathing trial. And second question is, can we use tube compensation techniques, eliciting tube compensation, keeping 100% tube compensation, and we assess whether we will be able to extubate even with the patient on ventilator with the CPAP, and can we use this negative inspiratory force also as a method to assess the readiness for extubation? These are my questions.
Yeah, thank you very much. These are a great question. So about the tube compensation during a spontaneous breathing trial, again, I would be favoring disconnecting the patient from the ventilator. I think the studies have nicely shown that, the point always is, if you intubate me right now and I have to breathe through the endotracheal tube, I have a higher airway resistance, right? That makes sense. But if the tube is in my trachea for like a week and you extubate me, I probably have some edema of the upper airways. So after extubation, my work of breathing is not lower as compared to just breathing through the endotracheal tube. And that is, I think, why several studies have actually demonstrated that the work of breathing is exactly the same if you are just breathing through the endotracheal tube without any support, without automatic tube compensation, as compared to extubation. So I think that's an important fact. So again, that's why I like no inspiratory support, no automatic tube compensation during a spontaneous breathing trial before the extubation. And I think that's also supported by this paper that was recently published in the New England Journal of Medicine, right? And sometimes people will say, is there a small group of patients where you do want to have a little bit of pressure support, patients with COPD or patients with heart failure? But especially in these patients, it is very important to see what happens when they lose the positive pressure, because they're going to lose positive pressure after extubation as well, right? So I think we have quite some data out there right now that the best way to predict a successful extubation is without additional inspiratory support, no pressure support, no tube compensation. And then we haven't really discussed into detail how long. I think mostly 30 minutes should be fine. If a patient has been on the ventilator for a long time, we might extend to 60 minutes, but usually 30 minutes. If the patient is doing fine after 30 minutes, he's most likely to be successful in the SBT. Actually, if you look at the literature very well, and if you look at your patient very well, you will be able to identify the patients within 5 minutes if he's going to fail or not. Well, that's a little bit difficult in clinical practice, so that's why we would say prefer an SBT for like 30 minutes.
Thank you. So there are a couple of questions in the chat box, I think almost around 20 questions. So for the sake of the time, we may not take every questions, but few important questions. So one question is from the Dr. Annie Soli. So basically, he has written that I am a student of anesthesiology of Sebias Marriott University, Indonesia. And I would like to ask, is there a role of different ventilator modes in more difficult weaning? Like, does the mode matter in the weaning? Or does the ventilator really matters in the weaning?
I think that's an excellent question. As we just mentioned, as compared to pressure support, in patients difficult to wean from mechanical ventilation, there might be some benefit of NAVA. But again, very few people do have NAVA available, so we should not spend that much time. But if you do have NAVA available in your ICU, I think patients difficult to wean, there is a benefit. Then there's some older studies out there that compare pressure support, assist control ventilation, and SIMV. And I think the most important thing is that probably SIMV is not a very good weaning mode. So either better assist control or pressure support, but not so much SIMV. But honestly speaking, I think the most important thing is the setting of your ventilator. If a patient is in pressure support, try to titrate the inspiratory support that the patient is comfortable. A lot of patients, as we will also recognize in different studies, get too much of a pressure support. People would say, well, 12 or 14 of pressure support makes the patient comfortable. But in a lot of patients, it results in overassist. It results, because of the hyperventilation, in apnea and backup ventilation. So I really think if you are carefully monitoring the patients and you take your time to optimize settings, the mode in itself or the ventilator brand company is not going to make a huge difference.
Correct. And also the another question is from one of the intensivists from Indonesia. So he has written that sometimes prematurely weaning the patient and then extubating and the patient again land up in reintubation. So are there any specific indicators monitoring when do we weaning from ventilator on these patients to avoid reintubation incidents? And second thing, like same question, what are our consideration during weaning from ventilator until we decide to do extubation? Like, yeah.
So these are very good questions. Thank you so much. The first thing I think is that we all need to accept that 15%, 18% of our patients will require reintubation, right? We do not have like a 100% test that predicts successful extubation. So, I mean, it's hard to say, but I think it is part of the game that some of our patients, 15, 20%, requires reintubation. There, and we didn't really have the time to discuss it into detail, there are a couple of strategies we can use to prevent reintubation, right? I think we're all familiar with non-invasive ventilation for patients with COPD, just prophylactic non-invasive ventilation. And the trial that is in my slides, but I did not discuss, also nicely show that in obese patients, so patients with BMI higher than 30, the prophylactic use of non-invasive ventilation for like 4 hours a day might play an important role in limiting the risk of reintubation as well. So I think there is, for selected patient categories, a role of non-invasive respiratory support, either high flow or non-invasive ventilation, to reduce the risk, to decrease the risk of reintubation. Again, most evidence for NIV in patients with COPD or in the obese patients or in patients that had recent upper abdominal surgery. So I think that is an important role to limit your risk of reintubation. But again, we have to keep in mind that whatever we are doing, there is a percentage of patients that will be reintubated. And if we want to reduce the risk too much, it means that some patients have been intubated for too much of a time, right? I mean, we have to accept that a percentage of patients is going to be reintubated, whatever we do.
Yes, another question is from India. Like both the questions are same. Like, what is your view on traumatic? What is your strategy for just a little more clarity on prolonged weaning protocols in prolonged weaning patients? And second thing is your view on traumatic brain injury patients weaning. So how do you plan actually in such patients, because they are having anticipated prolonged weaning also?
Yeah, I think these are also very great questions. So the traumatic brain injury patients, it's a very dedicated population, right? We recently had a paper in anesthesiology where we discussed the role of spontaneous breathing trials in TBI patients. And of course, these patients have a very different reason for difficult weaning. I mean, it's much more unlikely that in these patients that it is cardiac failure, it's respiratory muscle failure, it's mostly their neurological failure, right? So it's even part of discussions if it is useful at all to perform SBTs in TBI patients. I think if you're going to go to the paper in anesthesiology and the editorial, I think there's a lot of discussion whether we should do SBTs or not in TBI patients. It's a very selected population, and a lot of these patients, I'm not sure about the practices in India, but at least in our country, a lot of these patients end up with a tracheostomy tube, not because they are difficult to wean from the ventilator, because they cannot clear their airways. They need assist in suctioning, they need assist in coughing, right? And so the other question I think was about the strategies for prolonged weaning. I think it depends a lot on the underlying cause why this patient is difficult to wean. Again, if the patient is weak from respiratory muscle perspective, early mobilization, inspiratory strength training is important. But other patients, I think it's more like treating the underlying cause of cardiac failure. Not very often, but also keeping your diagnosis, perform full echocardiography. I mean, some patients will have mitral valve regurgitation that was not recognized earlier, or aortic valve stenosis that plays a role. So I always want to stress again and again, try to understand why this patient is difficult to wean. And in some of the patients, there's multiple reasons. So a comprehensive analysis of these patients is of utmost importance, I would think.
Professor Hank, I mean, what is the strategy of weaning in patients with mediastinal pathologies? Some patients have mediastinal tumors, and we find that they get extubated well immediately. I mean, patients are very conscious and they have good tone power, reflexes, and everything. And after extubation, we come to know, maybe after half an hour or 1 hour, we come to know that these patients again need reintubation and all that. How do we assess, weaning in these patients, and what will be the best strategy to wean? Otherwise, ultimately, they'll end up with the tracheostomy. So how can we avoid this? How do we assess readiness for weaning in these patients?
So there was a little bit of background noise. So you're saying patients with mediastinal tumor?
Yes, mediastinal pathologies. Some patients having intrathoracic obstruction.
Oh,
so
yeah.
These patients are really difficult to wean and difficult to get extubated also. So how do we wean these patients? What will be the best strategy to wean such patients?
Yeah, that's an excellent question. I think, well, again, it starts with understanding why the patient is difficult to wean, right? Is this because there is compression of the trachea, compression of the central airways, or is this because the tumor has affected the phrenic nerves or anything else, even in a patient with mediastinal tumors. There could be multiple reasons why this patient is difficult to wean. And we had these kind of patients in our center. And sometimes if there is compression on the main airways, we consider stenting the central airways, but only if we are sure that there is no lesion of the phrenic nerves. There's no weakness of the diaphragm, because, I mean, you can stent the central airways, but if there's another issue ongoing, I mean, that doesn't make sense, right? Because there's a lot of patients that do have compression of central airway, left main bronchus or whatsoever, who can be weaned from the ventilator. So it again is trying to understand, is this really the problem of the patient, or is something else going on as well? But I think this is a highly specialized patient population that need a careful evaluation to understand why these patients are difficult to be weaned.
Yeah. So there are one or two questions. Can we take if you have time, if you don't mind? Yeah.
Sure, no problem.
So, thank you. So somebody has mentioned regarding a Spanish trial. So when the patient is having a extubation failure or weaning failure, you put the patient back on assist control mode, or the full ventilation like control mode, or again back to the PRVC mode. So there is he mentioned that there is a Spanish trial. I'm not aware of that. So which is better? Like you try to ventilate the patient fully on sedation, again reassess, or you just again put the patient back on some kind of assist control mode and want to see. Then
yes, I would definitely prefer go back to assist control ventilation as soon as you can, because if the patient is in full mandatory ventilation, these patients are first at risk of developing disuse atrophy of the respiratory muscles. If they are hyperventilated, in controlled ventilation, the quality of sleep is affected. I don't think this is going to be very helpful in a weaning process. So in our center, and I think in a lot of centers, what we have seen, if the patient is reintubated, try to go back to assist control ventilation or assisted ventilation as soon as you can, and go through the differential diagnosis and see what the cause is. But I don't think there's a reason to go back to controlled ventilation at all.
Yeah. So there are a lot of weaning centers, dedicated weaning centers across the America and almost around Europe also. So what about Netherlands, sir? You have dedicated weaning centers actually, because sometimes the literature describes that patients who are on dedicated weaning centers are those mean for the weaning. Like in those centers, the outcome is better.
So
do you have respiratory technician? Do you have respiratory technician support? Does it make any difference? If we have a dedicated team which is looking after extubation and all that, does that make a difference as far as the outcomes are concerned?
Yeah, interesting question. There's some data out there to suggest that in the US, these dedicated centers, long-term weaning facilities or long-term acute care hospitals have improved weaning outcome as compared to the more general ICU. It's not very strong data, but it's data to suggest that these long-term weaning facilities do have a better outcome for patients. And I can imagine that if you have like this one long-term weaning facility with a lot of physios, respiratory therapists, other therapists that can support the patient and really are dedicated to optimize weaning strategies for these patients, it will be better. In Europe, there's a couple of countries that do have long-term weaning facilities. Right here in the Netherlands, we hardly have. I mean, in my previous university hospital, we did have a long-term weaning facility, and it was my impression that care at these hospitals for these dedicated patients is better. But in the Netherlands, there's very few long-term weaning facilities. I think it also has to do with the way how insurance is organized, right? I think that in the US, after some time in the ICU, reimbursement decreases. So that's why patients are admitted to this long-term weaning facility. In the Netherlands, that's not the case. I mean, hospitals get the same reimbursement. If your patient is in the ICU for 2 days or 100 days, the daily reimbursement is exactly the same. So I think that is why we don't have this weaning, not that much of these weaning facilities. But I would really love to see this developing in our country. So do you have this long-term weaning facilities in India?
We have something called as the rehab centers, like after the patient being weaned up from the ventilator for the chronic care. But there are very few hospitals, I suppose. Probably this concept is still evolving. Probably in some next few years, it might will come to India. So
Okay, that's very interesting.
yes, yes. So another question is from Dr. Rupak, like role of levosimendan during treating the diaphragmatic dysfunction, role of levosimendan. Does this drug is available till now? Because I think it's banned right now by the Drug Controller General of India. Levosimendan we are not using.
No. So that's an interesting question. We have actually, and I think the colleague asking the question is aware of that. We have conducted several studies on the role of levosimendan on diaphragm function. And I think there's nice data right now out there to show that levosimendan improves diaphragm function in healthy subjects, in patients with COPD. And some preliminary data also show that in patients difficult to wean from mechanical ventilation during a spontaneous breathing trial, levosimendan improves minute ventilation, improves tidal volume, and reduces arterial CO2. Whether it improves weaning outcome has not been investigated, but actually right now I am writing a grant from the Dutch government to get funded to perform a large multi-hospital, multi-center trial to investigate the effects of levosimendan on weaning outcome. So if you invite me next year, I hope I do have the answer to the question. We are using it sometimes in our ICU. If we do have patients that are weak and difficult to wean from mechanical ventilation, we might treat them with levosimendan, but remember, it has not been approved for that, and there's not much evidence out there. There is some basic evidence, there's some clinical studies, but I'm not sure yet if it improves really weaning outcome.
Yeah, because levosimendan we are not using in our center. Previously we are using it, but now we are not using actually.
Oh, okay. Yeah.
So yeah.
Basically, only for cardiogenic shock patients probably we were using, but not for weaning purpose probably.
Right.
So
no, there could be questions as well in patients that are difficult to wean because of cardiac failure, right? Could be because of diaphragm failure, but in patients with cardiac failure, and you don't want to start with dobutamine, or you don't want to start with phosphodiesterase inhibitors for several reasons, levosimendan is an interesting option as well. But we are more interested in the effects on the respiratory muscles.
Yeah. So I think we have almost covered a lot of aspect of the weaning, and I really thanks Dr. Leo for your excellent presentation and to be with us today in this evening and present the talk to our intensivist forum. So with this, I would like to conclude the session. Dr. Swapnil is there. If he is there, he can have some remarks, then we can conclude the session.
Thank you very much.
Thank you so very much. It was a real pleasure being here with you.
Yeah, so, yeah, sorry. Yeah, so so we would like to hear from you more and more, sir, in the future also. And now, if you're since you are coming to India also, we will meet in the next conference. So hope to see you soon. And
it will be a real pleasure.
Yeah, thank you, sir. Thanks.
Bye bye.
Thank you very much. Thank you. Bye bye. Good night.
Thank you, sir. Thank you, sir. Bye.